Hello, everybody, and welcome to the 23rd session of the European Journal of Cardiovascular Nursing's Journal Club. The journal is a member of the journal family of the European Society of Cardiology. In this challenging time, it's just great to be able to have the Journal Club to share research published in this journal. My name is Diane Carroll. I'm a nurse scientist at the Munn Center for Nursing Research at Massachusetts General Hospital in Boston. And it's my great pleasure to be the moderator for the discussion today. The purpose of the Journal Club is to bring alive some of the research published in the journal, hearing about the research from the principal investigator. I am pleased to be joined by Professor Felicity Astin, the principal investigator and lead author of the article, Cardiologists and Patients' Views about the Informed Consent Process and Their Understanding of the Anticipated Treatment Benefits of Coronary Angioplasty. Felicity is a professor at the University of Huddersfield and a consultant to the Calderdale and Huddersfield NHS Trust in the UK. We have worked together for over 10 years, and first on the Education Committee of ACNAP and now on research initiatives on informed consent. It's my really great pleasure for me to be here and to moderate this webinar. So to start us off, Felicity, can you tell us why you decided to investigate this particular topic area?
Yes, thanks very much, Diane, for this, for the introduction, and it is lovely to be here with you this afternoon. So why did I do this work? Well, basically, it goes back to when I was working in London in the 1990s, believe it or not, as a staff nurse. And at that time, coronary angioplasty was relatively new, and we were going through what's called now the stent revolution. So back in the 1990s, it was used predominantly electively for patients with chronic angina or stable angina. And I can remember looking after some patients in the hospital. And what struck me was that they really weren't very knowledgeable about what was going on, and they didn't seem to know very much about their health condition. And of course, they went home quite quickly, and at that time there wasn't any cardiac rehab or huge follow-up for that patient group. So that got me interested in understanding about, well, what do they do when they go home? What do they understand about their condition? Do they actually do any secondary prevention? Because let's face it, this patient group, stable angina, but they're at high risk of acute coronary syndrome going forward. So what are we doing to prevent that happening? So that was where the idea started. And then later on, I did my PhD, and I focused on understanding the illness perceptions, lifestyle change, and levels of anxiety, depression in patients having elective coronary angioplasty. And I won't talk too much about that, but one of the key findings that came out of that was the sample that I surveyed, which was 140 patients. This was in Australia, actually, at Monash University. The patients actually, nearly all of them thought they were cured, and they seemed to have a lot of misunderstandings about coronary heart disease and what they should be doing when they went home. So from that, I thought, well, we need to understand a bit more about the discussions and the patient education that happens upstream from the actual day they come in to have their elective coronary angioplasty. So that's where the idea came from, to understand about the informed consent process and the discussions that go on between healthcare professionals and patients.
Right. Well, that's very exciting to me that your research interest came from clinical practice. But before we talk about the results, can you tell us what makes a good informed consent process?
Yes, that's a really important question, Diane. So as we know, underpinning the whole idea of consent, seeking consent for an invasive medical procedure, is the idea of autonomy. So the principle that patients or people have the final say in what happens to their body, and they will or will not give permission accordingly. So the whole process is underpinned by this idea of autonomy. So if we think about the three elements that are very key to informed consent, Well, the first one is obviously that the patient's informed. So if we talk a little bit more about that, we would want the patient obviously to know about the procedure that they're going to have and to understand the risks, the benefits, what the alternative treatments might be, and importantly, what would happen if they decided that they didn't want to have any treatment. So they need to be fully informed about all those aspects of any potential medical treatment. Then obviously the patient needs to have capacity. So they need to be in a position at that time when consent is being sought. They need to be able to understand the information and to be able to make a decision based on their understanding of the information. And then thirdly, and importantly, consent needs to be given voluntarily. So it's really important that they're not being coerced in any way by family, friends, or health professionals. So just to recap, the patient needs to be informed, they need to have capacity, and they need to give their consent voluntarily.
And is informed consent a legal requirement?
Yes, it is a legal requirement, and as I've already said, an important ethical principle. And the legal frameworks will vary between countries. Certainly in the UK, at the moment, the General Medical Council are rewriting the policy that underpins the way we do informed consent for invasive procedures in the UK. And certainly in this version, there's very much more emphasis on the shared decision making and on the dialogue that takes place between the patient and the healthcare professional.
That's excellent, because I think that's a really important aspect that we really need to spend some time with. So let's get to your study that you published in the journal. What were the specific aims for the study that you undertook?
Okay, there were two key aims. So first of all, we wanted to understand a bit more about the views of cardiologists about the informed consent process, and also the views of patients about the informed consent process. And then we actually wanted to understand if patients really know about the treatment benefits of angioplasty. So we know that PCI, percutaneous coronary intervention, is a generic umbrella term for a particular approach. In this study, we were focusing on elective and acute angioplasty, so not primary angioplasty patients, but half of the sample were elective angioplasty patients and half were having angioplasty done acutely. But it's just to be clear, it wasn't primary angioplasty, because obviously the consent process is going to vary significantly according to how much time you've got to do it. Okay, so those were the two aims.
So two very different populations in some regard. So I'd be interested to understand the methods that you use to get at the data from a physician group, as well as the really important data from the patient perspective. So tell us a little bit about your design and methods.
Okay, Diane, yes. So we decided that we would do a survey and that we would use a questionnaire. We had a look at the literature and there weren't any questionnaires that we could specifically use. So what we used was a researcher generated tool. So we had two different questionnaires that were conceptually identical. One was for the cardiologist sample and one was for the patient sample. And as I say, they were conceptually identical. But for the patient's questionnaire, we had the items more in lay terms, so that they could understand those really clearly. So the electronic survey was sent out to a sample of cardiologists across the UK, and we accessed that through a professional database. So we sent the e-survey out to 600 cardiologists. We were a bit disappointed with the response rate. Unfortunately, only 121 got back to us and 118 completed it. So the response rate for that was 16%, which again, disappointing, but we still had the views of over 100 cardiologists. Then for the patient sample, we did this a little differently. We used a paper-based survey, and we had a stratified sample across 10 different NHS trusts. And so we'd selected different trusts according to the number of procedures they did. So we had smaller and larger PCI centres, and also obviously in different geographical regions. So it was 346 patients we got data from. So we were lucky. The response rate was much better for patients. It was 82% response rate. So we feel quite confident about the generalizability of the data from the patient sample.
That's great to see so many patients having an interest in completing a paper survey at a time where things were a little unsettled for them. So from your data, can you really talk a little bit about some of the key results at this point from the study that you did?
Okay, Dan, thank you. So I picked out 3 sort of highlights that I thought would be useful for people. So the first one was about the items that we asked the patients and cardiologists about their attitudes towards the actual informed consent process. So we compared the results from the doctors and the patients, and it was interesting because there was a statistically significant difference. And I guess the key message is that the doctors seem to value the informed consent process a lot more than the patients did. And in fact, looking more closely at the data, we found that about 40% of the patients agreed that they relied on their doctor to make the decision for them. So that was an interesting finding for us because it shows that patients are quite passive in this process. We had actually done another qualitative study, a sister study, where we'd interviewed 40 patients having coronary angioplasty, and the same sort of findings came out, that they played quite a passive role in the overall process. So I suppose a key thing from that is we need to find ways to get patients more involved in the informed consent. And as we know, one way forward might be to involve family members or friends and try and get them to be there during the informed consent process. And we did ask, there was an item on the survey about this, and 47% of patients said they would like a family member or a friend there. So almost half the sample wanted somebody there during the discussions about the informed consent process. So that's the first key finding that I'd like to share with you. The second area I'd like to talk to you about was about their understanding of their health information. So again, thinking about what the cardiologists thought and what the patients thought. When we asked the patients if they remembered or understood the information that they were given ahead of coronary angioplasty, 40% said that they didn't remember or understand the health information that was given to them. So again, that's quite a striking result, really, because we would hope that it would definitely be more than, more than that, number of people who would understand what they're signing up for. And interestingly enough, over a third of the cardiologists also agreed that patients don't remember the information that's given to them. So this shines a spotlight really on an area that I think we really need to work on to try and improve, to try and ensure that the discussions that take place ahead of signing a consent form are more effective, and that the patients have got a better understanding of what they're saying yes to. So that was the second part of the results that I wanted to share with you. The third part was about patients' understanding of the treatment benefits. So they've signed up to have a coronary angioplasty. Half the sample are having an elective coronary angioplasty, and the other half are having it in an acute setting. So maybe for unstable angina or for non-STEMI, but again, not for primary angioplasty. So it was very encouraging. All the patients we asked, again, it was over 300 patients, they all understood that they would get, they were hoping for symptomatic relief from having coronary angioplasty done. But when we asked them about cure, 60% of them thought coronary angioplasty was a cure for their coronary heart disease, and over 90% thought that they would live longer and that their risk of having a heart attack in the future was reduced. So we can see that there are some serious misconceptions there. Obviously, for the acute angioplasty patients, the prognostic impact of coronary angioplasty is different to the elective group. But we know with the elective angioplasty patients that coronary angioplasty isn't going to make them live longer or reduce their risk of a heart attack. We know that it's predominantly for symptomatic relief. So reflecting on that, I was quite interested because I thought, well, you know, it's over 20 years ago that I did my PhD, and from that, it was done in Australia, a different country, but patients thought they were cured and that the treatment, angioplasty, was a fix. And here we are, 20 years on, another study done in England with, you know, a relatively largish sample, and we've got similar sorts of results. So it just feels like, to me, we haven't made very much progress in getting patients to understand a little bit more about their treatment.
Mm. Well, it's interesting. I think these three key findings really point to a need for some now evidence-based improvements, certainly around getting patients to agree that this is a valuable experience, to be able to know what's going on, to fully understand what's happening to them, and then to have an understanding of the really true benefits of an intervention that they've agreed to participate in. So this clearly identifies some really good areas for an improvement in the process and a better understanding of patients and where they're coming from, especially when patients arrive at these tertiary care sites from a variety of different locations. They come either from a primary care provider or maybe from their own cardiologist, and yet you don't know what they know in order to make good decisions. So it's really, this is a really important study from a patient perspective to fully understand where we need to work to improve this consent process. So when you think about what you found in your study, what would you consider key implications for clinical practice or quality improvement or performance improvement in the consent process in the UK as well as internationally?
Yes. Well, I think a really important thing is that we need to involve the family and significant others. We need to involve them in the process. And I understand that for urgent procedures that are done in an emergency, there's going to be less opportunity to do that. But if we think about elective angioplasty, certainly here we've got significant waiting lists of weeks. So hopefully it should be possible to plan an opportunity for consultations and the informed consent discussion that take place with a family member there, if the patient indeed wants that. And as I said, the results from the study showed that over half of the patients do want that. So I think we need to ask during the consultation or ahead of the consultation if they want somebody present with them. And I think that would be an important way of hopefully improving engagement in the informed consent process. So that would be the first thing. I think the second thing we need to look at is the health information resources that we give to patients. I think we need to co-create those with service users, and we need to pay special attention to their health literacy levels, because we know that often the medical terminology that's used in such health information is actually quite difficult for people to understand. So we definitely need to, I think, improve some of the health information that we give to patients to make it more accessible to them. And thirdly, I think we need to support health professionals with extra training, and we need to help them develop their communication skills. And there are several communication techniques, such as Teach Back, that people could use and integrate into their practice. And I think that would improve things as well. And also decision support. You know, there's quite a few decision aids out there. and those can be really useful as a tool that can help to augment the discussions.
When I think about, that's great, because when I think about family, the potential of the patient not really having a keen interest in understanding what may be happening, but the family really wanting to know more about some of the risk-benefit profiles allows the patient in a sort of backwards way of gaining information that they didn't want to ask about, but the family felt comfortable in asking about. So I think the process of including family, which I think is a very important part in providing that environment for a shared decision-making about a procedure that they're undergoing, is a really key piece to a performance improvement in the consent process. I think consenting originally was just sort of a pro forma. We just have to do it, so we'll do it. And now we really need to have providers and nurses and physicians all think about the fact that we're all working on this together, and that this is really a team approach to a decision about having a procedure done. You mentioned you have done, did you want to say something? Go ahead.
Well, I was just going to pick up a little bit about risk, because I think discussions about risk are particularly challenging, because there are some patients, you know, I've interviewed people who've actually said this, that they don't really want to know anything about the risks. Mm-hmm. So that actually puts the cardiologists and the specialist nurses in quite a difficult position. And also, when we talk about risk, what sort of risk do we mean? Do we mean we're going to talk about the sort of risk for the general population who's having a coronary angioplasty, which we know is very low? Or are we talking about a patient who might have quite a high risk factor profile, lots of comorbidities? They wouldn't have the same level of risk. So it needs to be individualized in some way. And I think that's quite challenging. And then you can also bring in, well, what about the operator? How successful are they? You know, do we talk about their track record? And that's another risk. So it makes it quite complicated, especially talking about risk in a way that people understand.
And how much risk do people really want to know about if the percentages are down to like 0.1% risk of something? Yet I think I stated that most of these patients really wanted to know about most of all the risks that potentially could happen. Yeah.
Yes, they did, even though obviously the risk of death from coronary angioplasty, especially elective coronary angioplasty, is very low. I guess it's still important to acknowledge that there is a very tiny risk of death. And, you know, we need to be able to have these conversations in a way that the patients understand. So we don't want to make people excessively anxious, because that isn't what we want to do. Yeah. But by the same token, they need to be aware of the real picture. So it's a challenge.
Yeah, I would agree, because how much of that emotional burden, which potentially could happen as a result of a risk discussion, do you want patients to have during what would be considered a sort of a different procedure, something that they wouldn't be undergoing normally? So yeah, you're right. It's very challenging, and it needs to have an astute consenter to look at the patient and the family and make those kinds of decisions. You had mentioned that you had developed some educational resources. Could you share some of those with your colleagues here about that you could be used for informed consent, or how to get a hold of those resources? That would be great.
Yes, absolutely. And as we all know, research is great, but unless it actually makes a difference to practice, then it's not doing what we want it to do. So in that way, I'd love to hear from anybody who wants to work with me to change the consent practice in their own organization. So please go ahead and email me. It's f.astin@hud.ac.uk. So I'm very happy to get individual emails from people who would like to collaborate with me and the other people that I work with to look at the informed consent process in their own organization. And in fact, Diane and I have been doing the same thing, haven't we, Diane? Comparing notes between England and USA, Boston. So the resources that we've got or that we're developing are some health information resources that are quite picture heavy, that are done very much in plain language. So we're in the process of developing those. We'd be happy to share them, and we're aiming to produce them in a way that the text could be translated into different languages if somebody in a different country wanted to use that. We're developing some PowerPoint educational resources as well for healthcare professionals, and we do have some of those available for people to look at if they want to. Again, they're freely available, happy to share. And we also have gone through a process of getting patient feedback in some different cardiology departments. So we've got some key questions that we've used. So those aren't necessarily research, it's more about the service, but we can share some of those resources with people as well if they would like. So very keen to share.
Thank you very much. Well, I think this has been a really an informative presentation that certainly brings, as I would say, to life the perspective of informed consent for coronary angioplasty, both from the physician and the patient perspective. Identification of the patient's role in the process, the need to reiterate the benefits and to clarify risks are now evidence-based improvements that you have identified for the informed consent process. Thank you and your team again for this work and for you to take the time to present your data. Again, Felicity can be contacted at f.astin@hud.ac.uk. We hope the listeners have enjoyed the discussion, and we look forward to continuing to use the ACNAP page on the European Society of Cardiology website to be informed of the research of the European Journal of Cardiovascular Nursing. We hope to see you in the future, and we thank you for listening to us, and thank you, Felicity, for presenting this data.
Thank you very much. I've really enjoyed it. Thank you, Diane, and thanks to everyone who's listened. Bye-bye.
Bye-bye.